Okay, wonderful. So I'll start the talk with the left atrial appendage occlusion first, and you can go to the next slide, please. So the first question we need to ask ourselves is the LAA responsible for strokes? And this is just a TE image of the left atrial appendage showing a nice big thrombus, as you probably all have seen in your careers. And the next image shows a left atrial appendage in three-dimensional view. You can go to the next slide, please. This shows the thrombus in a three-dimensional view. I hope the slide plays, so you can click on the slide, please. Okay, and this is another image from an article in Circulation 2006, a very impressive case. You can see a thrombus in the left atrial appendage, which during the TE actually embolizes. And so I think if you click next, there's no doubt that thrombus in the left atrial appendage can cause a stroke. Let's go to the next slide, please. I think we all know that anticoagulation with vitamin K antagonists, in this particular case warfarin, decreases the stroke rate. And if you go to the next slide, or next click, you'll see that most of the large-scale trials, the SPAF, SPINOF, AFSAC, have shown about a 50 to 70% stroke risk reduction with warfarin. Next slide, please. You can go to the next click, please. However, only about 50% of INR levels are in the therapeutic range, and too high INR and a too low INR are either associated with bleeding risk or with stroke. And as you can see on this slide here, the yellow line shows ischemic stroke rate, which increases with an INR below 2, and you can see in the red line the intracranial bleeding rate, which obviously increases with a high INR. And next slide, or next click, please. You can keep going. You can keep going, next one. And also, of course, warfarin is associated with a significant bleeding risk regardless of the INR level, and this includes intracranial hemorrhage. Let's go to the next slide, please. Hence, I think it's not surprising that about 50 to 70% of all patients with atrial fibrillation at risk of stroke are actually not treated with oral anticoagulants. And if you go to the next click, please, you'll see on the slide that this shows patients at different age categories on the bottom of the slide. You can go to the next click, please. And on the left-hand side, you can see how many of those patients actually were treated with warfarin that had indications for warfarin. Next click, please. And you'll see that probably only about a third of patients who would be eligible for warfarin are actually receiving warfarin. And click the next, please. And next click, please. And so there are, of course, the novel anticoagulants, which include apixaban, rivaroxaban, and there are various other new anticoagulants. But I think all of them have advantages, which are that no monitoring is required and less drug-drug and diet-drug interactions are present. And there's probably, at least in all three trials, equivalent stroke rate reduction with new anticoagulants. However, next click, please. And next click. Also, the novel anticoagulants are associated with a significant bleeding risk. So if you look at the next click, please, you'll see that looking at RELY, ROCKET AF, and Aristotle, which evaluates the new anticoagulants, that there's a significant bleeding risk even with the new anticoagulants. Next click, please. You can see it outlined here. Next click. And one more click. So this shows the bleeding risk, major bleeding risk on warfarin versus the novel anticoagulants, the dabigatran, rivaroxaban, and apixaban. Let's go to the next click, please. Next click, please. So I think there is definitely a role for isolation of the left atrial appendage from the systemic circulation. It may lower stroke risk in the absence of oral anticoagulation. Next click, please. There are various different techniques used. Next click, there's surgical closure, there's percutaneous closure. Next click, there's a minimal invasive closure technique. I will not focus on the surgical closure during this presentation, and you can click about 3-4 times. What I'll focus on today is really percutaneous closure, and mainly with the devices that have received CE mark. This shows the Watchman device here, and the next click will show the ACP, the Amplatzer cardiac plug, which is produced by St. Jude Medical. You can click the next one, please. This actually shows the ACP plug. The left side version is the older version. On the right-hand side, you can see the newer ACP2 plug, which is also called Amulet. And the next click, please. And finally, there's also minimal invasive closure techniques, which includes the Lariat device. You can click one more time. Click one more time. And so how is it done? Today I'll just show a case with the Watchman device, which is the device that has been studied most extensively so far with 2 large trials. Next click, please. First, you need femoral venous access and transesophageal echocardiography. And then preceding that, you have transseptal puncture, which is preferred typically in an infra-posterior location to allow more coaxial alignment of the sheath with the left atrial appendage. You should, of course, avoid using a PFO because a PFO has a more anterior location, which sometimes makes sheath alignment quite difficult. Next slide, please. And this just shows the basic anatomy of transseptal puncture. And I know that in India, you probably all are much better at transseptal puncture than we are here in Germany. Next click, please. This outlines the intraatrial septum, as you can see here in the pathological specimen. And you can see the fossa in blue. Next click, please. On the right-hand side. And then you can see the various different borders of the intraatrial septum. Next click, please. You can see on the posterior aspect, there's the posterior wall of the right and left atrium. On the superior aspect, next click, please. You can see the superior vena cava and the roof of the right and left atrium. Next click, please. And then the superior anterior location is the aorta, which is really the structure that's most important to avoid. Next click, please. And then antero-inferior is the tricuspid annulus and the coronary sinus. Next click, please. And then inferiorly, you can see the inferior vena cava. Next click, please. Some operators use a pigtail catheter to position it in the non-coronary cusp of the aorta. Next click. And this helps you to guide your transseptal puncture. We currently don't do this anymore because we have very good TE guidance during the procedure, and so we typically don't put the pigtail catheter in the aorta. Next click, please. And you can keep clicking one more. Okay, so this is the traditional system of transseptal puncture. Next click, please. You can actually click a few clicks, maybe 2 or 3 clicks. Okay, there you go. This shows the transseptal puncture system. Next click, please. There's a needle, which is also called the BRK needle or Brockenbrough needle. Next click, please. This needle is outlined here. Next click, please. And you can see that the needle, of course, is hollow. It has a very sharp tip, and at the proximal portion of the needle, next click, please, is an arrow, a metal arrow. This is very important to orient your sheath. Next click, please. Then there's also proximally a valve, which needs to be connected to a transducer, so you have continuous pressure monitoring during the procedure. Next click, please. And then secondly, you have the dilator. Next click, please, and you have the sheath. The first thing you do is you connect the dilator into the sheath. You flush both systems. Next, please. You can click forward 2 or 3. And then after that, what you do is you insert the needle into the dilator. You can click a few clicks here. So that's the sheath outlined here. Next click. That's the dilator going in the sheath. Next click. Now you can see the needle being advanced through the dilator. Next click, please. And it's important to recognize that if you advance the needle all the way to the hub of the dilator, then the needle tip actually exits the sheath. Next click, please. And you don't want to have the needle exit the dilator or sheath until you're really sure that you're absolutely at the area that they want to puncture. Next click, please. So this shows if you advance it all the way up to the hub. Next click. Then the tip of the needle points outside or exits the dilator. Next click, please. So you want to keep the needle or the arrow, the metal arrow of the needle, about 2 finger breadths away from the dilator. Next click, please. Next click. This actually shows the procedure. So you start with a venous access. Next click, please. and then you advance a 0.035 guide wire, typically into the superior vena cava. Next click, please. This shows it here, and following the guide wire, you advance the transeptal dilator and sheath. Next click, please. Then you remove the 035 wire. You put up the Brockenbrough needle or BRK needle. Next click, please. Here's the wire removed, and here's the Brockenbrough needle inserted. Next click, please. Good. Next click, please. This shows the actual Brockenbrough needle, and like I said earlier, before you advance the needle all the way to the hub, you should keep about 2 finger breadths between the metal arrow, next click, and the hub of the dilator. You can see it here. Next click, please. Next click. Good. Next click. All right, next click. And then what you do, you actually turn the metal arrow, which hopefully is seen here on the screen. You turn the metal arrow to about a 5 p.m. position, considering that the patient is, the ceiling would be at noon. So you turn it to about 5 or 6 p.m., and what this does is it orients the needle and the whole transeptal system towards the interatrial septum. Next click, please. And then as you take the sheath back, next click, please. There's usually a double hump as you take the sheath back into the right atrium, and then when it enters the fossa ovalis. Next click, please. Then you can look at the position under fluoroscopy to make sure that you're inferior of the aorta and posterior. Next click, please. Next click. Good. Next click. All right. And then you can also inject some contrast to verify your position at the interatrial septum. Next click, please. Once you're at that position, you can actually see that under TE and fluoroscopy, and what you can see here is advancement of the needle through the dilator and sheath. I don't know if you can make the video play one more time. Good. So here you see the needle being advanced through the interatrial septum right there. So you advance the needle through the dilator and sheath once you're at the right position. And let's go to the next slide, please. I think this might not play, but this is supposed to show the needle entering the left atrium, and you can actually see the needle going through the septum, and you can see contrast being injected. You can then see the contrast actually on the TE imaging, but I think this slide might not be playing. So let's go to the next slide, please. Then also, as you're doing the procedure, what you should do is you should have a pressure transduced. You can see on the left-hand side of the screen is a pressure tracing. Next, please. And the pressure tracing, when you have the needle abutting the interatrial septum, is typically dampened. Next, please. And once the needle actually penetrates the interatrial septum, you have a pressure spike, and then finally you get the left atrial pressure. Next, please. If you don't see left atrial pressure, that's really important, then you should really think about what the reason might be. You might be abutting the opposite left atrial wall, which could be dangerous if you kept going. Or you might have thrombus within the BRK needle. So you should really do a search for reasons if you don't get a left atrial pressure tracing. Next, please. And next, please. Okay. And this actually shows, now you have the needle in place. It's across the interatrial septum. When a needle is across the interatrial septum, what you do is you hold the needle in place and you advance, or actually you hold the needle and the dilator in place and you advance the sheath into the left atrium, which is shown here. And next, please. And then don't forget to administer about 5,000 to 10,000 units of IV heparin to get an ACT of about, I would say, 250 to 300 seconds. Next, please. Then finally, what you do is when you have the transeptal sheath in the left atrium, you advance an extra stiff amplatz guide wire into the left upper pulmonary vein, which is shown here. And next, please, next slide. And then when you have the extra stiff guide wire in place, you remove the transeptal sheath and you advance the access sheath, which comes with the device. This is a double curve access sheath. There's also a single curve access sheath, but we typically use a double curve sheath because it aligns slightly better with the left atrial appendage, depending on its morphology. But you can see what double curve means on this slide. There's a curve in one plane, and there's also a curve in a second plane. Next slide, please. And then what you do is, once the extra stiff amplatzer is in place, you exchange the transeptal sheath for this access sheath. The access sheath has markers on the distal tip, several markers. And with that sheath in place, you can advance a pigtail catheter into the left atrial appendage shown here. And you can do an injection and make measurements. Next slide, please. Measurements of the left atrial appendage, both at the ostium and at the landing zone. Next slide, please. I think I went too far with the slide, but that's okay. So once you have the pigtail in place, you advance the access sheath over the pigtail into the appendage, and then you advance the actual device, which comes in another delivery catheter, into the access sheath all the way to the tip. And when that's the case, then you can, in the next slide, you can see pulling back the access sheath and the delivery catheter while keeping the Watchman device in place. The Watchman is attached to a delivery cable. So you hold the cable with one hand, and you basically pull back the delivery sheath or access sheath and delivery catheter, and this unfolds the Watchman device as you're pulling back. So you can see this, I think, shown in this slide. I hope you can see it in India, because here it looks a little bit grainy, but I hope you can see it on the slides there. Yeah, next slide, please. Good, good. Next slide, please. And then finally, you can do an appendage angiogram and make sure that your position is adequate. Go forward one slide, please. Good. Next slide, please. So where's the data? Of course, you know, the data is, compared to the anticoagulants, it's somewhat limited because the studies are not as big as what we're used to from anticoagulants. But there's a PROTECT-AF trial, which has about 700 patients enrolled. And then there was a PREVAIL trial that was more recently published. Next slide, please. This is the PROTECT-AF data. You can see on, this is the event curve for stroke, cardiovascular, or unexplained death, or systemic embolism. On the bottom, you see the time in days, and on the left-hand side, you see the event-free survival. And as you can see, there's really no significant difference between anticoagulation and LAA closure. Next slide, please, or next click, please. You can keep clicking about 2 or 3 clicks. You can keep clicking a little bit, good. This is the PREVAIL data showing ischemic stroke and systemic embolism rates, and you can see, next click please, that between device and control group there was really no significant difference. Next click please. And what I haven't mentioned really is the 5-year data that was recently presented at the Denver Heart Rhythm Society meeting, where actually the PROTECT-AF patient group, or the data from PROTECT-AF out to 5 years showed that there was a mortality benefit in favor of LAA closure, and the ischemic stroke rate remained the same between both treatment groups, but the hemorrhagic stroke rate was significantly less with the LAA closure. So in conclusion, next click please. Anticoagulation reduces stroke risk and atrial fibrillation. I think nobody would argue with that. Next click please. Many patients are not good candidates for anticoagulation due to significant bleeding risk. Next click please. Percutaneous LAA closure is an alternative to anticoagulation, I believe. Next click, please. 2 randomized controlled trials have demonstrated non-inferiority to anticoagulation. Next click, please. And LAA occlusion should be considered, in my opinion, in patients with atrial fibrillation, particularly in the presence of a high bleeding risk. Thank you.